Hello, guys. Let's start this meeting, this lesson together. Before, let me thanks so much Professor Bak Nguyen for inviting me in this meeting, and also for the very nice introduction from Professor Lei Ding Tong. Basically, the idea to deal with this title, it is in keeping with the LGBT issues, because LGBT issue means inclusion, and inclusion means culture. So basically, we will try to go into this idea of understanding how sexual health in humankind is tremendously important for the general health. This is coming from the International Society of Sexual Medicine, but also from the Hanoi Medical University. I am very proud to be a distinguished professor in this university, which is my second one. So I really feel at home here in Hanoi. So let's start with this agenda. We will try to understand what is natural, what is cultural in sexuality, in sexual medicine, so nature and culture. We will also try to understand the cultural use of sex, but also I would like to change your perspective, how you are thinking about sexual health, how you are thinking about the also reproductive health. Then there is something which is very important for me, which is the so-called mind and body dichotomy. Mind in one part, body in the other part. We will understand how much this perspective is wrong. We should have something else, something different from this body-mind dichotomy. Then we will go to the so-called biopsychosocial model, which is very popular. Everybody is talking about the biopsychosocial model. It is a very good model to understand the sexuality, but we can do better. We can have something else, and we can propose here the new perspective that we called system sexology. So we have time to go in this journey in order to understand what a system sexology is. There is one housekeeping information, very important. Please block me and ask me anything that you want to know. I will be more than happy to interrupt me and to explain better. So feel free to interrupt me in any moment that you want to make a question. If I'm not clear, if there is something that you want to know better regarding what I'm talking about. Okay. It's not working. Okay. So few years ago, I wrote this book together with one of the key opinion leaders in psychology, Dr. David Roland from the Valparaiso University. And the idea of that book was to show how much the medical practice, the daily practice of sexual medicine is tremendously influenced by the cultural differences. So in other words, the idea is that if you are dealing with the sexual health without knowing the culture, the perspective, even sometimes the religion of your patients, you are making a lot of mistakes. Sexual health is something which is tremendously related to the culture. And in fact, this one is a kind of guide for the sexual health practitioner, because we really believe that it is something very much related to the culture And the nature and the nurture in sex are tremendously important. Both are tremendously important. So what means cultural and transcultural differences? It means that in behavior, in general, in all behaviors, and in particular in sexual behavior, the cultural differences are producing values, are producing beliefs, are producing something which is transforming the personal, the individual culture. And this is impacting into the relationship, into the relation with the other member of the couple. Furthermore, there are transcultural differences. What means transcultural? It means that into the global village where we are living, there is a kind of transfusion of cultures. For example, we are dressing using more or less, let's say, Western dress, which is in the majority of the part of the world. This is transcultural. It's not the traditional way of dressing. And this is very important because it is determining the transition of the people, of the individuals, of the group of individuals from one society to the another. So we are in the global village, and this is also very important to understand how much this may impact into the sexuality, to the sexual health in general. For example, I have also some experience in China, and in particular with the traditional Chinese medicine. I'm not expert in traditional Chinese medicine, but I just wanted to show this article, which has been published 2 weeks ago in Andrology. Andrology is probably the most important journal in the field of andrology in the world. And I was very proud to be one of the authors of this article, because it's showing that even Western medicine is now open to traditional medicine, and in particular traditional sexual medicine. So I don't know if you know this term, feng shui. It is a Chinese term which means a kind of positions, sexual positions, which may produce a health or disease, which can be used in order to increase the knowledge of the patients, both from a physical and a psychological perspective. In Feng Shui, it is also present something related to the sexual position and the sexual techniques. You can say that it's close to Kama Sutra, but it's not Kama Sutra, it's something completely different, actually. But the Feng Shui means also a way to treat the sexual diseases and to avoid some risky sexual practice, and also knowledge related to reproduction. So what is the message? The message is that basically you should be open not just to Western medicine, but also to the several traditions where Asia is rich of. And I think that this is very important to have this message, which is trying to put together the medical classic, the so-called immortality techniques, the classical prescription, as well the classical traditional Chinese medicine. So it is a kind of experiment to create a mix, an open mind, because one risk of sexual medicine, even if sexual medicine is a young discipline, one major risk is to be too much narrow, not open to the novelties, and not open to the past also. So we should be able to look in the future, but also to have a look in the past, in order to build this new field, which is sexual medicine. So there is a kind of evolutionary tree. Tomorrow in the afternoon, when we will meet again, we will deal mostly on Darwin and into the evolution of sexuality. But there is also something that you can consider as an evolutionary tree. For example, regarding the field of psychology, I think that some psychologists are there, so they could be interested in the fact that from the beginning, the psychology was just a matter of talking, but then the medicine was coming in, that is called psychiatric, and then there is a biological attempt to explain the psychiatric problems. And this is the same for medical sexology, for sexual medicine. From just talking with the patient, just listening the story of the patient, to the psychosexology, and now the medical sexology, which is the sum of psychosexology, urology, endocrinology, and all the fields, and gynecology, of course, all the fields which are interested in sexual health, in sexual reproduction. So this is a book another book that I wrote with one colleague from the psychiatric field. And the idea is that we really need a kind of renaissance of the psychiatric sciences related to sexual medicine. It is a matter of fact that the psychiatric field is not too much interested in sexual medicine, and which is a nonsense, because it should be very important to have the psychiatric culture inside the sexual medicine. And in fact, if you have a look on these guys, I don't know how many names you can know, like Sigmund Freud, like Ivan Bloch, William Master and Virginia Johnson, Wilhelm Reich, Ernst Grafenberg, all those guys are being psychiatrists. But now the number of psychiatrists really interested in sexual medicine is really low. So we should increase also the number of psychologists and psychiatrists. And all those guys are being psychiatrists. And also, we have to say that in the history, sexual medicine was considered a kind of a revolution. And in fact, the Nazi tried to destroy sexual medicine, and in particular, the field of sexual medicine dealing with LGBT issues, with homosexuality, transsexuality, and so on. Despite the fact that, again, that field born in Germany, that field born in the psychiatric environment, but the Nazi tried to destroy, to burn the books, and to destroy everything related to this field of science. And this is a survey that I did a few years ago related to the attitude of the Italian psychiatrists with the sexual medicine, which was very, very low. So the Italian andrologists are a little bit changing, and there is definitely a need for a broader cultural knowledge. There is a need of care in sexual and reproductive medicine, which is which must be considered absolutely multicultural. And this is the numbers comparing the knowledge related to several things like erectile dysfunction, like premature ejaculation, like infertility, comparing Europe, non-Europe, Africa, South and Central, and North America. As you can see, there is a huge difference into the attitudes of the andrologists dealing with the sexual issues. But you know what is the DSM-5? The DSM-5 is the Bible of the psychiatrist. It's something that the psychiatrist is using always. And the DSM-5 is writing that everything which is related to the mental health is having something related to the culture. And the culture is producing a kind of framework interpretative. It means that it is needed for the interpretation to shape the experience, to understand the expression of the symptoms, of the signs, of the behaviors, and the criteria for diagnosis. So in other words, the idea is that without knowing the culture, you will not be able to deal with mental health, with the sexual issues, with the reproductive issues. And this is also important considering other things like the family, the society, the institutions. Remember this because I will be back on this idea of the importance of the society, of the importance of the politics also, the institutions also in producing sexual health or not producing sexual health. So the DSM-5 is also dealing with something which is cultural. In other words, which is related to the culture. And the culture is very important in producing symptoms into the groups, into the community, as well into the context, but also the distress itself and the terms used in order to understand what the distress is really impacting into the sexuality in general, in mental health, but in the sexual health in particular. And again, the cultural explanation, it is modifying completely also the perception of the etiology, the cause of the symptoms, the illness, and the distress. So there is a kind of differences which are encountered. So the construct of the meaning of the disease, I will explain at each point for you later, and the role of the authority and the role of who's possessing like the relationship between the patient and the doctor, and which is the source of the information. For example, you know that many patients are using Dr. Google instead of going to the real doctor. They are keeping information from the internet, not really from the doctor. So this is a very important way how the communication between the doctor and the patient is going. And it is also very important to understand which is the distance that we should have with respect to the patient and how close we should be with the patient, with also some risk, of course, related to this point. And there is also an important point, which is about the role of the family. For example, let's talk about my family. My wife, she stopped to smoke many years ago. And when she stopped, I tried to continue to smoke my pipe for about 6-8 months. And then I stopped because I realized that I cannot smoke if she was not smoking. So this is the typical representation of how the family could be tremendously important. And we call it the inflammatory or non-inflammatory family. So in other words, the family can improve good behaviors or can make bad behaviors even more risky. So that's the reason why the role of the family into the decision-making is very important regarding general health and in particular sexual health. And finally, last but not least, the gender issue. in many, many countries, the term gender is even forbidden. And this is absolutely ridiculous, but it is true that in many political environments, they are trying to forget anything which is related to the gender, because they consider that just two genders exist and nothing else. And those issues could be tremendously important and impacting gender and sexuality. So there are kinds of differences encountered, and for example, the construct of the meaning of a disease. So this is a concept very interesting, which is the concept of the illness without a disease. Illness without disease is growing as a very important issue. One typical representation of it is vulvodynia. Do you know what is vulvodynia? Vulvodynia is a very frequent condition. Many girls, ladies are complaining for this kind of pain, which is without disease. So in other words, the gynecologist is usually unable to find any physical representation of this tremendous pain, which is coming from the vulva, which is coming from the female genitals. And this does not mean that this disease does not exist, that is just in the mind of the patient. It means that we don't know yet what vulvodynia is. So it is very important also to admit that those diseases, those symptoms are also tremendously impacting into the emotional states, and emotions are also modifying very much the somatization, which means how the body is transforming the bad things that the mind is producing in physical symptoms, and how the different culture may impact in the model of disease, and how we as doctor, as psychologist, as medical doctor, can modify the way how the patient is conceptualizing, is understanding, is suffering from those illness. So those are typical questions that you can use in your daily clinical practice. I think that this, you can take a picture of this because it's very important in the daily medical practice to use those questions and to understand the way the patient is understanding his own symptom, her own diseases. It is a very nice way to deal with it. Okay, now I wanted to represent something which is quite incredible, but very interesting. And the name of this symptom, it is khoe. I don't know if you know it. It is a kind of condition, symptom, disease, where the patient is afraid of having lost his penis. The idea of the patient is that the penis is lost. There is a disappearance of the penis. The khoe is typical of the south of China, in Guangdong province. This is the region where it has been an epidemic, let's say, of khoe about 40, 50 years ago. But it is very interesting because it is something which may also occur in female, where they are afraid of losing the labia or the breast. And it is a kind of, let's say, hysterical condition, but very interesting, because it's a kind of dysmorphophobic disorder. You know what means dysmorphophobic? Dysmorphophobic is a Greek term, which means I am afraid of something of my body, which really is not so important. It's a typical dysmorphophobic symptom where the patient is afraid of the size of the penis. When the penis is normal in size, but he is afraid that his penis is not big enough, this is a dysmorphophobia. And this is occurring also in female for the breast, for the size of the vagina, for the shape of the labia. It is a typical dysmorphophobic condition. And it is very interesting because it is occurring also in Singapore, in Thailand, as well in India. So it's something that I never read something about it in Vietnam, but I think that we should be also aware of the possibility that some patient may develop this, let's say, hysterical perception of having lost the penis completely. And also some suicides occurred because of the choro, because of this condition, which is definitely cultural in nature, because the choro is not occurring in other countries, in other cultures outside this part of Asia. So again, this is coming from the philosophical perspective, where there is, you know, in the Taoism, into the Chinese tradition, there is this dichotomy between the male and female energy, where there is the yin, which is negative, female, passive, weak, while it is the vice versa of the yang, which is the male, positive, active, strong, like the sun. So the moon and the sun. And this is present very much into the Chinese, but Oriental in general, philosophy. And of course, we have to know it because there are also something very interesting. The fact that this symbol that everybody knows is very popular is also telling something. It is telling the union. It's telling the unity. And I think that we can keep something from it. The idea that the coital union is a good way to understand the human sexuality. So there are, of course, a risk about the having just a cultural perspective on sexual medicine. So we must be able to connect together cultural and scientific issues together. But we have to admit that, for example, the social norms could be tremendously important in producing a poor sexual education. And also, it could be a risk to have a confrontation with Western models too strong. So basically, the idea is to produce something which is considering the tradition, but also mixing the tradition with the Western science. And yes, this is another way to describe the choro and the risk of the choro in the south of China. There is another point which is a culture in nature, which is related to the kidney. You know that in the traditional medicine, the kidney is the source of sex, is the source of sexuality somehow. And it is true that actually the kidney is having quite an important role also in the Western culture, in the Western medicine. And in particular, this is what we call the post-orgasmic illness syndrome. I don't know if you are familiar with. It is a condition where the patient is experiencing not fatigue, but tremendous fatigue after the orgasm. The patient is, I remember very well, one patient who is unable to wake up from the bed for 1 week after each ejaculation. After one ejaculation, he is staying in the bed for even 1 week. So it is very interesting to consider the post-orgasmic illness syndrome as also something related to the culture, but also to the couple, because the couple, the relationship, the intimate relationship, it is tremendously influenced by this condition. It is a rare condition. It is like described here in this book from Kobe Reisman, rare sexual medicine conditions, but it's not so rare. Actually, we are now know that is much less rare than was believed before, where the patient is trying to avoid ejaculation, to avoid the sexuality, and to avoid also any kind of eroticism, and they feel very guilty. But also the partner is involved in it and producing avoidance of sexual activity and the lack of intimacy, distress, anger. And of course, the couple is destroyed. The couple is distressed. There is a huge dissatisfaction. So I say that the kidney is important in the traditional Chinese medicine, but also in the Vietnamese traditional medicine. And there are several things which are not so far from the reality. For example, we wrote this review talking about clotho, which is a protein produced by the kidney. It is quite an important protein, actually, for the health of the kidney, but the same clotho protein is also important for testosterone production, for testosterone activity. So the idea that the kidney is important for sexuality, which was present in the tradition, it is quite a good idea, a real idea. And there is a huge correlation between that production, the kidney production, and the testosterone production. So the kidney and the sex are much more related than was believed before. Those are Cochrane studies that I did many years ago, showing how much renal failure is producing sexual diseases, and in particular hypogonadism, and in particular erectile dysfunction. So in keeping with the traditional Chinese medicine perspective. And which is the reason? Let me be back to my original expertise, my original background. I am an endocrinologist. So what's happened when the kidney is not working? This is the normal production of the GnRH. GnRH is a gonadotropin releasing hormone, which is produced by the hypothalamus in order to stimulate the hypothalamus pituitary gonadal axis. So 3 stations: the hypothalamus in the top in the brain, then the pituitary, which is producing LH and FSH, luteinizing hormone and the follicular stimulating hormone, and finally in men, testosterone, in female, estrogen and progesterone. Okay, GnRH is working only if there is a pulsatility. It means that only if there is a well-working clock into the brain, the GnRH is producing that way. The clock must producing a pulse every 90 to 120 minutes. If your hypothalamus is producing too fast the GnRH, so less than 90 minutes, you are castrated. If your hypothalamus is producing one pulse more than every 120, more than 2 hours, you are also castrated. So the pulsatility of the GnRH is tremendously important. If the GnRH is going this way, you are healthy and you are producing steroid hormones. You are producing testosterone, estrogen, and progesterone. But if your hypothalamus is unable to go in this chronobiological way, in producing those pulses, there is a castration. And this is occurring in renal diseases, in renal failure, because the kidney is unable to process a GnRH molecule so that the molecule is remaining in the blood. And this is exactly as the urology is doing when he's using GnRH analogs in order to castrate the patient with prostate cancer. It is exactly the same mechanism. So when you have, for example, transplantation, the kidney is working again. There is again the pulsatility, and the pulsatility means good production of gonadotropins, good production of LH, good production of FSH, and there is a resumption of both testosterone and spermatozoa production, as well ovulation and estrogen and progesterone. So this is just to show that at the end of the story, the tradition of considering the kidney important for general health, but in particular for reproductive and sexual health, was not so wrong, actually. And this is exactly what I was mentioning. Here is the GnRH producer into the hypothalamus, and then the signal is going to the anterior pituitary, producing LH and FSH in this pulsatile way, in this pulsatility, and this is the unique way to have enough testosterone concentration. Sorry, let me go back. Yes, this is the demonstration of it. It is something that I'm very proud of because it was my thesis of MD, so it's something very, very old, where we compared 2 different patients, normal subjects and impotent patients with psychogenic erectile dysfunction, with non-organic erectile dysfunction. As you can see, here the pulsatility is normal, and the testosterone levels are normal in the normal people having normal sexual activity. But when you compare with a patient with huge psychological problems, the psychology of the patient is modifying very much the ability of the hypothalamus to produce a GnRH. There is a lack of pulsatility. There are no pulse into the GnRH. And finally, low level of testosterone. Low in the low normal range levels of testosterone. Very, very interesting. So there is several differences that we may encounter, which are related again to the relationship, the source of information, and the manner of communication. And this is also very important when we are dealing with immigrants. I think that also this country is going to be more open to people coming from other countries. So once again, the culture is very important in understanding how people believe his sexual health and sexual diseases. And this is there are some articles showing how much the culture and the language and all those issues which may produce barriers or health. And that this is also in particular very important when dealing with the LGBT issues, because the culture as well the religion may really modify, may really produce what we call the homophobic behaviors. Let me explain what is homophobia. The Greek term phobia means irrational fear. Okay, if somebody is coming from this door with a gun and I am afraid of this guy, this is not irrational. This is a logical fear. Okay, so it's not a disease. It's something absolutely healthy. The guy is coming with the gun, and so I am afraid. But if somebody is coming with the flower for me, and I am afraid, this is irrational fear. It is something wrong. Homophobia is the irrational fear for homosexual people. The homosexual behavior is not harming anybody. If somebody is doing something in his own house, in his own bed, with adult people, there is no any harm for the others. So why some people is afraid of the homosexual behavior? We have to conclude that it is a kind of psychological or psychiatric disease. It is a phobic behavior, which means irrational fear. There is no reason, just cultural reasons, that people have been educated to be afraid of different sexual behaviors. But there is no reason for this fear. I'm not talking about what the people believe. I'm just analyzing the real situation. The real situation is homophobic behavior is an irrational behavior, an irrational fear related to the sexual behavior of the people, which should be absolutely private, which must be absolutely preserved. And this study was trying to demonstrate how the homophobic attitudes are also present into the students, into the medical and psychology students. We compared the 3 different countries, Italy, Albania, which is a Muslim country, and Ukraine, which is an Orthodox country. And we demonstrated that there is not issue related to the religion, but to the fundamentalism. The fundamentalism is when you think that your religion is that one must be observed by everybody. When I wanted to impose my religion to others. So it's not the religion itself, but the fundamentalism which is producing homophobia. And those are also other articles. Okay, I think that we already did this one. And it is very interesting, the fact that a few years ago, the LGBT movement was, let's say, able to modify a little bit. But again, the culture and the policy are very important and able to modify and to make even worse the situation, as we are afraid is going to be in India, for example, where there is a kind of going back to the LGBT rights in that country. This is very interesting. It is a kind of practical flowchart which can be used in order to, let's say, break the ice regarding the cultural issue in the patient with a sexual dysfunction. And as you can see, there is something which is related of issues masking sexual health concerns, but also your need as the doctor to start the discussion, to be open to the discussion about the sexual health, and your ability to show how much you are open for the discussion and the awareness related to the sexuality. And for example, very simple questions that usually doctors are not doing, not using. How is everything at home? How it is your relationship? How you want to further discuss? And of course, when the patient is not interested apparently in further discussion, you have to respect, but also you have to demonstrate to the patient that when she is ready for further discussion, you will be open for it. And there is a kind of a brainstorming that it could be very important. So you may continue from the previous step, understanding how it is the sexual relationship, if the patient is enough open for it, trying to understanding the past history, the personal history, in particular, the use of smoke, of alcohol, of homosexual or heterosexual sexual behavior, how much the masturbation is used, which is a very sensitive argument, but tremendously important for the sexual health. And as well, the use of pornography, which is also in a young generation quite frequent and could be harmful if there is not a sexual education, as it is in many, many countries. Also, the family and the family history is very important, and you have to understand how there is the interaction between wife and husband, how it is connected with the society, which is the relationship with the children, and the frequency of sex, as well as the medical issues. When you are addressing a sexual problem, you have to consider the different aspect, which is that one of the desire, that one of the excitation, which means erection in male, lubrication in female, the pleasure, the what is called penetration of during the sexual intercourse, as well the satisfaction. The penetration is also called the plateau phase. And you can also use questionnaires, psychometric questionnaire, validated questionnaire, in order to assess, well, the desire is not so easy to be assessed by questionnaires, but the excitation, male and female arousal could be, as well the orgasm with the orgasmometer. And here are the differences where, for example, people may deal with desire regarding the attitudes with the desire, how much is the desire, how the partner is attractive, but also vice versa, how I am attractive for the partner. As well, the excitation, the arousal, the erection, I am able to maintain my erection or my lubrication, in the case of female. If my erection is lost shortly after the penetration, and what I'm feeling when my partner is touching me, I have another patient who is completely unable to be touched into the genitals. I don't know if you saw such a kind of patient. He is tremendously afraid when even the doctor is touching the genitals, the penis or the testis, the patient is screaming, is something that he cannot tolerate at all. And this is also related to the lubrication, of course, and related to the pain, which is a very important issue for, of course, for female. What about the orgasm, the ability to ejaculate in vagina? For example, some patients are unable to ejaculate in vagina because they are afraid of what? Of the paternity, of being father. And so they have this kind of symptom of inability to ejaculate in vagina, or the amount of pleasure, the amount of pain during the ejaculation, for example, and the premature ejaculation, when the ejaculation is occurring before the female orgasm. The penetration, which is, I highlighted this one because it's quite closer to the previous issue, and I will be back on it, showing something new about this. The feeling of the patients that the penis is more or less lost into the vagina, that we call the lost penis syndrome. And I will show you about this. And see, this is something that I'm just showing you to demonstrate how interesting and complex the story is. And this is indeed the lost penis syndrome that we defined a few years ago and we published in Sexual Medicine Review. It is a condition where, for several reasons, the patient is not perceiving the friction during the penetration, and he felt that the penis is lost. Is not producing any strong sensitivity, and he may lose a direction, typically. And there are several conditions which are producing the lost penis syndrome. Some of them are anatomical, some of them are produced by the doctor, like, for example, antipsychotics and antidepressant drugs, which are reducing the strength and the size of the penis. Some are behavioral, like what is called idiosyncratic masturbation, the masturbation too frequent, too strong, using a too big pressure, also the anorgasmia, and what we call the couple pose. This is another term that we created, when there is the sum of the andropause plus menopause. In that case, could be also present the lost penis syndrome. But there are also psychopathological conditions producing like specific phobic behaviors, like obsessive compulsive disorder, OCD, like schizophrenia, CORO, that I already mentioned, as well as the other dysmorphophobic disorders. So we are now in the first conclusion. The first conclusion of this part of the story is that a few humans' behaviors are under the control of a complex pathway of rules, of thoughts, and a way of life, what we generally call the culture, then sexuality. So sexuality is tremendously related to the culture. What we are calling the science of sex, sexual medicine, is something which is definitely complex. And be aware of the people who are trying to give you simple solution for complex problems, because you can be sure that she is wrong. Because very much to read this book, which is a very small book, very short one, is one of the last Bowman wrote about what's called the liquid love, because it is theorizing that into the liquid society we are living. Again, I'm not so sure that you can understand what liquid means. Liquid means that it's changing very rapidly. It means that you cannot block in one single frame, and you cannot have borders, because the culture or the things are going outside the borders. And this is also present into the human sexuality, as I will show you here. This is my interpretation of the Bowman theory. Basically, the idea is we have three steps, three levels. The first one, in the first one, which is the natural level, the level of the nature, it is that one used by the animals, where the aim of sex is just reproduction. All the animals are making sex only when they are fertile. There is a unique exception, which is the bonobo. The bonobo is the dwarf chimpanzee of Africa, is the unique one which is having sex outside the reproductive time of the female. All the other animals, your pets, your cats, your dogs, they can have sex only when they are fertile. So the aim of sex in the natural way is reproduction. But this is not the case of humans. We are able to make sex outside the reproduction, outside the fertility, outside the so-called estrus. Estrus means the timing when we are fertile. And this is what was happening during the so-called sexual revolution. You know, the sexual revolution in the 60s and the 70s of the past century, more or less when I'm born, more or less, where the aim of sex was love, which was a kind of revolution because people were not having sex for love before, not so frequently, just in some romantic situation. But usually the families are built for economic reasons, for good relationship between families, but not for love. Love was something which was really present into the world culture only 50 years ago, not so many years ago. And it is a kind of a cultural threshold. Cultural threshold means that this is a second step. The aim of sex is love. What's happened now, which is called the postmodern era, according to Bauman. Now, young people, mostly young people, are having sex not just for reproduction, not just for love, but also for pleasure, which is a huge cultural novelty. It's completely changing our paradigm. And we have, of course, to consider it. We have, of course, to face it. And what is very interesting is the fact that each step is not destroying the other one, but they are surviving together. So that your patients who are coming to your office, they may be more traditionally linked to this model where the reproduction is the center of the sexual activity. Many other patients could be more close to the love model, where the aim of the couple, the aim of sex is love, and the sex is, let's say, part of love. But mostly in the young generation, the young people may consider also the fact that orgasm, pleasure, is the real aim, the real scope of the sex. And again, it is very interesting the fact that these three models are surviving at the same moment in our society. So our society is very mixed with all three models. Yes, for example, this is quite an interesting article I found here, actually, in the north of Vietnam, into a Tuao Chau district, which is a particular district with a particular culture, where this is what is described, this very recent article, which has been published a few weeks ago in 25, where the scientists discovered a kind of gap between the knowledge and the action. So the participants know where to assess contraceptives, for example, but they still lack confidence in the use of contraceptives. This lack of confidence is drove by fear of judgment from what? From the family, from the peers, from the doctors also. So again, the culture is tremendously important. And this gap is even bigger when we are considering the cultural norms, when we are considering the traditional gender roles, once again, LGBT issues, the expectation of childbearing, which is able to limit the autonomy of the patients to make a decision, to produce decisions, in particular regarding for the adolescents and girls into the ethnic minority communities. So I think that is a typical model of how the culture may dramatically impact on the sexual health and reproductive health of patients. But into the contemporary Vietnam, and you can tell me how much I'm right or I'm wrong, in the contemporary Vietnam, slowly, there is a change in the purpose of sex in the Orient. Into the main cities like Ho Chi Minh City, like Hanoi, of course, the young generation, this is my perception, is going to shift a little bit from the procreation model, the first step, to the recreational model. Even if the romantic and the traditional perspective, as far as I understood, are still present and are still strong. So your ability as a future doctors in sexual medicine, dealing with sexual medicine, will be to understand those differences, the fact that those differences are present and in the same situation. So let's make the second conclusion. The second conclusion is that the postmodern era where we are right now, 2025, in the postmodern era, there is something characterizing continuous changes and the co-presence, the coexistence of different traditional as well postmodern behaviors. And this is definitely challenging the intervention in the sexual health. So we definitely need to modify, to change our paradigm, as for example, in this picture of transsexual patient subjects. Okay, now let's go to something else. What I wanted to do right now is to destroy your way to think about what is body, what is mind. My purpose is to cancel from your mind the idea that the body is something separated from the mind. So basically, I wanted to modify the dichotomy as well as the so-called exclusion diagnosis in sexual medicine. What means exclusion diagnosis? It means that if you look at the books, it is always written that if there is nothing physical and I have a sexual problem, this must be psychological in nature. This is the exclusion diagnosis. It means that if I am excluding all the physical problems, it means that I should be psychogenic in nature. I should have a psychological problem. So my aim now is to destroy it. So to do it, I will show you some short clinical cases. Let's go to the first one. 3. She's a Vietnamese girl. And she is not able to lubricate when she's with the boring husband. The husband is young but boring, not particularly intelligent, not particularly nice, not particularly kind. But she is able to lubricate, to excite herself, and also to have orgasm when she is having sex with the professor of English literature. So she is having an affair with the professor of English literature. Okay, now I have this question for you. You know the clinical case. My question is, she's anorgasmic with the husband, but with a full orgasm with the professor. Is she psychogenic? Is this condition psychogenic in nature? I wanted to know your opinion about. Tell me what you think about this very simple clinical case. It is a psychological one. It is a physical one. It is a Vietnamese case, so you should be familiar. I don't know how frequently the female wives are having affairs with the English professors.
I think it's an interesting case. And firstly, I think string is affected by psychological hypolubrication. Also, I think his husband's sexual skill may affect to her lubrication. So I think both physical and psychological causes.
Okay. Thank you so much. But I wanted to know from you, do you agree that we can use the term psychogenic, like written here?
I think yes, we can do. Yeah, we can use it. Yeah.
Okay, great. Thank you so much. I will try to demonstrate why I'm a little bit in disagreement about it. And thank you very much for your help. In the reality, Finn was affected by an hidden condition, which is subclinical hypothyroidism. So the thyroid was apparently normal, but not normal enough. And it's not easy to find subclinical hypothyroidism. You need a good endocrinologist showing this condition. And the subclinical hypothyroidism is a condition which is occurring and appearing when she is into stressful condition, like that one when she is having sex with the boring husband, so that the lack of thyroid hormones are making her much less able to lubricate, while vice versa, when she is having sex with the nice professor of English, despite that he was older, but more kind, more nice, and also more culturally interesting, she is able to lubricate because the impact of lack of thyroid hormones was not enough to block the lubrication itself. So this very simple clinical case is demonstrating that perhaps the definition of a psychogenic is not the correct one, because we have to remember what psychogenic means. What does it mean? Literally, genic is a Greek term which means generated by. Psycho means mind. Psychogenic means generated by the mind. But in that case, was, yes, of course, generated by the mind, was, of course, generated by the relationship, was, of course, generated, as you correctly said, very, very correctly, by the lack of skills by the husband, but also from the body, from the thyroid, which was not working enough. So the term psychogenic cannot be really used, because, again, psychogenic means generated only by the mind itself. So we have to start in sexual medicine to talk about risk factors, like hypothyroidism in this case. And hypothyroidism is, in this case, a risk factor, as well as the partners itself, the husband or the professor, for the appearance of the sexual symptom, as we discussed in this article. So, in the Western idea, in the Western philosophy, in the Western science, there is a kind of separation between the mind and the body. And these separations are kind of pillars for the science, but wrong pillars, actually, because those pillars are producing two monsters. The first monster is the medical reductionism, typically urological in nature. Everything is all in a pill. Just take a pill and your sexual problem will be solved. It is a tragical mistake. But another monster, identical monster, vice versa, is the psychological reductionism. It's all in your mind, which is completely wrong. Because the previous patient, if you are treating the previous patient just with marital therapy, just with a psychological therapy, without considering the fact that there is a lack of thyroid hormones, you will never succeed. Never. So, the idea that the sexual dysfunction can come from the body or can come from the mind is something that we must change, which you should modify. So many years ago, I wrote this article about the issue of the Manichaean diagnosis in sexual medicine, comparing organic and psychogenic issues. As I said at the beginning, there is this exclusion diagnosis, which means when there is a sexual symptom, for example, erectile dysfunction, the patient is coming in your office, you are studying the biological risk factors, and you can decide if the patient is with a biological etiology, and you call it organic erectile dysfunction. But if you are unable in your clinical workout to find any physical problem, you are unable to identify any biological or physiological factor, so that you are calling the patient affected by psychogenic erectile dysfunction. And you are going to go for the psychological therapy. This is the tragical mistake that I want to change, because the term psychogenic is an obsolete term. It is based to the body-mind dualism, to the separation of the mind from the body. And there are several reasons why it is obsolete. The first, because the term psychogenic is redundant. Redundant means that it is useless. And it is useless because all the sexual dysfunction are also impacting into the mind, into the relationship. So why you want to call psychogenic one patient and not the other one? This is a huge mistake. All the patients with a sexual dysfunction, they have anxiety and depression. They have psychological problems. Even the diabetic patients with a lot of physical risk factors must have a psychological impact of his own or her own condition. So why you wanted to add the term psychogenic, which is completely redundant, useless, because all the patients are psychogenic. So there is no need to say, you are psychogenic, you are organic. All are psychogenic. Even if you are finding a huge physical risk factor. The term psychogenic is obsolete because it is abusive. What means abusive? It means that you do not have any tool, psychometric, physical, mechanical, any kind of tool, able to demonstrate that in that particular patient, the mind is producing the sexual symptom. For example, if I have a pneumonia, you can look for the etiology of my pneumonia. You can find bacteria, you can find COVID, you can find the cause, and you have tests in order to demonstrate that my pneumonia is due to that particular cause. Do you have the same instrument for the psychological problems? No. There is no one single instrument, both physical and psychometric, that you can use to demonstrate that that patient, that symptom is just caused by the psychological problems. Of course, if you are using a psychometric test for depression, for example, for anxiety, for example, for alexithymia, for example, you will find a lot of evidences because they are present in the patients with sexual dysfunction, always present. But you cannot say that this is the cause. It is a comorbidity, tremendously important to be addressed, tremendously important to be considered, but you cannot say, like COVID and pneumonia, that there is a causal relationship between the etiology and the symptom. This is the major difference. But let me go ahead. It is obsolete also because it is stigmatizing the patient. Labeling the patient with the term psychogenic into the perception of the patient means I am crazy. The patient hopes to be discovered for something physical. The patient don't want really to be diagnosed as a psychogenic one, because he believes that the psychotherapy, which is completely wrong, psychotherapy is a never-ending therapy, because she believes that it is expensive, it is time-consuming, and he wants the solution immediately. So in any case, those are wrong conditions, but ideas. But definitely, it is stigmatizing, illegally stigmatizing. You cannot stigmatize the patient with the term, the label, psychogenic. The term psychogenic is obsolete because it is also risky. And I want to demonstrate how it is risky, because in the majority of the flowcharts, in your textbook, in the guidelines that you are following, into the talks from the key opinion leaders, the psychotherapy is just for the patient with psychogenic issues, the psychotherapy, which is completely wrong. In my mind, the counseling, talking therapy, even psychotherapy should be done for every patient with a sexual dysfunction. Remember that the most important sexual organ is not between the legs, it's between the ears. So, of course, we must address it with counseling, with a talking therapy, with a psychotherapy, not just for the patient with a psychogenic condition, but almost for all the patients with a sexual dysfunction. So that is another reason why I consider the term psychogenic completely wrong and even risky. And finally, the term psychogenic is obsolete because it's based on the exclusion diagnosis. It means that the exclusion diagnosis, as I said, is something that you perform when you are exploring all the possible physical causes. But how you can be sure that tomorrow somebody will discover another tool in order to demonstrate unknown causes, physical causes of erectile dysfunction or any sexual dysfunction? For example, when Master and Johnson wrote their own book on sexual problems, it has been written in 1966, about 50 years ago. They say that they wrote that 95% of the patients with erectile dysfunction are psychogenic. But in 1966, no radioimmunoassay for hormones. So they don't know anything about hormones. No Doppler examination for the vessels. They don't know anything about the vessels, about circulation. No neurological assessment. They don't know anything about the nerves producing or not producing the erections. So the exclusion diagnosis was simply ridiculous, because at that time, those tools were not available, which are now available. But we can be absolutely sure that if I'm coming here in this university in the next 50 years, as I hope, we will make a completely different medicine. We will have completely new tools. And we will discover new reasons for having a sexual dysfunction, which are currently unknown. So the idea of the exclusion diagnosis is simply ridiculous, because tomorrow we will discover new tools which will show organic physical causes for the sexual dysfunction that we don't know yet. And then the term psychogenic is producing monster and mistakes and clinical mistakes. And this is because the patient considered psychogenic is treated by psychotherapy, maybe without medicine, which is a mistake. And those classified as organic sexual dysfunction are treated with drugs without psychotherapy. And this is very far from the evidence-based medical perspective. Now I wanted to bring you into completely another field, but very close actually, which is the field of hypertension. Hypertension is the most common cardiovascular symptom, you agree? Which is the percentage of the patients with hypertension where you can find a physical cause, a physical etiology. In which percentage? You can find a physical cause. You can call organic hypertension, which is the percentage. 5%. Only 5% of the patients with hypertension, you have an organic etiology. In 95% of the patients with hypertension, you have a lot of physical risk factors, but no one is considered etiology, but risk factors. So, are you calling the 95% of patients with hypertension as affected by psychogenic hypertension? Definitely not. Which is the term that you are using for calling those patients? Idiopathic hypertension. But you know what means in Greek idiopathic? The term idiopathic, what does it mean? I don't know. means I don't know. Idiopathic means I don't know, which does not prevent the doctor to give antihypertensive drugs, which is not preventing the doctor to change the lifestyle of the patient, which is not preventing the doctor to talk with the patients about, for example, the changes on the environment. So in the case of hypertension, we are not separating the body from the mind. We are considering together in the same way. And the doctor who is not addressing, for example, the lifestyle of the patient is a good doctor. No, he's not. He's not addressing in the hypertensive patients. He's not addressing the relationship with the boss in the work, which is producing a lot of hypertension. He's not a good doctor. If the doctor is just giving the pill, take the pill and this is enough, he's not a good doctor. But at the same time, if the doctor is just talking about the mobbing, about the situation at work, the situation in the family, without giving the antihypertensive drug, the patient will die for a heart infarction. So why we want to use a different way of thinking with respect to hypertension when we are dealing with sexual dysfunction? It is something which is absolutely ridiculous. It is absolutely a nonsense. So medicine, all the medicine around the world agrees that hypertension is called idiopathic in 95% of the situation, when there is a unknown cause, unique etiology, but many risk factors: smoking, drinking too much, not moving, wrong diets. All those lifestyle-related issues are definitely producing this condition. And it is very important to unify the diagnosis as well as the therapy. So my third conclusion is that in the modern sexology, we have to produce a kind of revolution to stop, to separate the mind from the body. And we have to stop to think into this binary way, mind and body, and to start to think into an holistic way, where the healthy sex, the good sex, it is obtained with the full, without limits, interaction of the mind with the body, and also considering the environment. So in my mind, the diagnosis and the treatments.
Thank you.
Okay, guys, let's go back to the lesson. Thank you for your patience. And I know that I was a little bit too philosophical, too complex in my previous part of that lesson. I hope that the next will be a little bit more easy and also somehow even more practical. So basically, we may start from defining what is the biopsychosocial model. The biopsychosocial model is the current model used in sexual medicine. You will find the biopsychosocial model everywhere. In all the books, in all the guidelines, is always written biopsychosocial model. What means? It means that each sexual dysfunction should be considered in the light of the body, in the light of the psychology, in the light of the social aspects. So let's see if this is currently working, well working also now in the modern sexual medicine. The idea of the biopsychosocial model, BPS model, was produced in the 70s by a psychologist, George Engel, who was trying to face the huge presence of the doctors in the field of psychology also. It was not for sexual medicine. It was something for everything related to the health. It's a kind of alternative produced in order to face the prevailing biomedical model of care. Only body, only medicine, only diagnosis, medical diagnosis, nothing in the mind. So Engel was trying to understand how to make borders to the biomedical model, the unique way of thinking on the body without considering the other aspects. Because he felt that there is a need to include into the health evaluation what is related to the person experience, as well to the attitude of the patients, attitude of the persons, related to the illnesses, related to the patient itself as a person, as well also the social factors, the society, how the society is producing or not producing health or disease. So this is the model of the biopsychosocial model, where there are physical illnesses, the comorbidities, the age, for example, the medication, the lifestyle, like smoking, drinking alcohol, and drugs, and this is attaining to the biological aspects. But Engels also said that are at least important, at the same importance, the psychological issues like the cognitive aspects, the mental health aspects, the development of the patient, the so-called attachment styles, so the way of the relationship with the caregiver in the early stages of the life, as well the traumas. And finally, last but not least, the social aspect, like the importance of the family in producing diseases, like the importance of the partner in producing diseases, the religion, as well the societal norms, the society. So quite interesting, quite nice, quite good. So the biopsychosocial model, it is having also a huge benefit. It is producing positive effects and good outcomes, because it is centered for the first time not on the symptom, but on the patient. Not on the disease, but on the patient itself. And using the biopsychosocial model, centering everything on the patient, on the couple, it is increasing the satisfaction of the patient with respect to the healthcare services, with respect to the consultation. Furthermore, the patient is more prone to collaborate with the doctor when the care of the patient, the care of the sexual disease is patient-centered, producing individual needs, attention to the individual needs, considering the expectations of the patients, and all those are explored and addressed through the biopsychosocial model. As a consequence, and this is an article that I wrote about this BPS model, as well another things that I wanted to make a short parenthesis, which is the sex-positive approach, very important for when considering the LGBT community. Sex-positive means that you must respect everything which is related to the human sexuality from other patients. You should not use your own ideas in order to judge what is right, what is wrong, when two adult and happy subjects are having sex. So the biopsychosocial model is definitely the unique approach in order to give an holistic care, as we said before, as well to consider the diversity, the inclusion as a target that we should reach when dealing with human sexuality. However, as everything which is human is also having some limits. And let's show which are the limits that are characteristic of the biopsychosocial models. There are pitfalls. In fact, in that way, sexual health is just considered as produced by biological, psychological, and social factors, which is not by itself a mistake. But what is true is that at the end of the story, if you are measuring the amount of the studies related to the social aspects related to sexuality, you will find that there is a very small amount of studies with respect to the studies related to the biological aspects. So in other words, it seems that the biopsychosociological model is very interesting, but at the end of the day, it is producing just few studies related to the sociological aspects. Furthermore, there is a negative attitudes related to the sexuality within the society, which are impacting into the healthcare system, which are producing interaction, which are influencing the employment, the occupation related to sexuality, the sexual function, which are not completely understood or addressed by the psychosocial model. And also there is a little attention related to the desires of the patients, the needs of the patients, and the values of the individual patient itself. Furthermore, the role of the pleasure, the role of the diversities within the sexuality is not always really considered. But why? Because the term biopsychosocial model, which is three terms, biology, psychological issues, and social, is usually understood as two terms, body, bio, and psychosociological, one other one, as a unit. And this is producing, again, a kind of dichotomy. Let's go to a very simple clinical case, another one for you. Now we have another Vietnamese subject, and this guy is affected by hypoactive sexual desire disorder. So he went to the endocrinologist like me, and the endocrinologist found andropause, late onset hypogonadism, low levels of androgens. And he gave him testosterone because there is a lack of testosterone. But also the psychosexologist, which was interacting with the patient, he found low sexual interest in the wife because she was in menopause, the condition that we called couple pause or double pause, as in this article we published in Sexual Medicine Review last year. So at the end of the story, the treatment with testosterone was not enough to produce an amelioration of the sexual desire of the patient. In the reality, it has been discovered that that patient was a follower of an hyper-religious sect, which was proclaiming the chastity as a kind of political solution, crazy solution for all the problems of the society. So that clinical case is showing that addressing the biological issues like testosterone, addressing the psychological issues like couple pose could be not enough. And you need some cultural skills in order to understand, for example, this particular condition of the follower of this kind of strange religion, which was tremendously impacting into the clinical manifestation of this subject, of this patient. So we can go to the number 4 conclusion, which is that one. The BPS model, the biopsychological model, is very good. It's great. It is excellent. But in the reality, the same key opinion leaders who are dealing, talking, representing the biopsychosocial model are the same who are using the Manichaean separation between the mind and the body, are the same who are using the term psychogenic that we did talk about before. So in the reality, the biopsychosocial model is a table not staying on 3 legs, but on 2. Body, mind, and society as another leg. And you know that when a table is standing on 2 legs, the table cannot stand. There's something wrong. In fact, very frequently, the biopsychosocial model is a kind of alibi masking something which is really binary in nature. Once again, mind and body. Mind, society and psychology, and body. So usually there is a very small attention to the real social, the real cultural, the real political, the real economical aspects. And in fact, as written here, several supporters of the biopsychosocial model are the same who are talking about the psychogenic erectile dysfunctions. So we should try to find another model. And we call this new model, this new perspective, system sexology. And I will explain you why it's called the system sexology. Basically, I stolen this model from a famous one, which has been created a few years ago, many years ago actually, by Bronfenbrenner. The idea of this sociologist is that each subject, each of us, each patient, this one, is at the center of several systems. And he called the microsystem, the small one, like, for example, the family, the partner, which is the immediate environment. But that one is surrounded by the connections between the environments that he called mesosystem. And that one is also related to what? To the society in general, to the political issues in general. And this is indirect environments producing the exosystem. And again, for example, if you consider an entire culture, let's say the Vietnamese culture, for example, this is the macro system where there are culture, society, values. which are impacting dramatically into the subjects. And then finally, the timing, the chronosystem, because what is now could be different tomorrow. What is now is different from yesterday. So also this is very important, how the change over time are doing. So the Brofenberg bioecological model theory, it is very important. It is considered very important now, not just by me. It is quite a universal way of thinking, because it is representing the complexity of the several interactions producing health or disease into the subject. So again, microsystem, mesosystem, exosystem, macrosystem, chronosystem. So the relationship, the individual, family, friends, partners, microsystem. Mesosystem, the several microsystems, which may influence the life of the person. The exosystem, you know the term micro means small, meso means in between, exo means outside, macro means big, and chrono means time. Schools, healthcare, media for the exosystem. Macrosystem society, religions, culture, well-being, and the timing, how it is changing over the time. So let's talk, in order to demonstrate what I'm meaning using this theory, let's talk about this graph, which is very famous. Everybody knows what is. This is happening also here. It is the drop of the number of spermatozoa ejaculated by each man for each ejaculation. So in few years, as you can see, there is a dramatic drop of the number of healthy spermatozoa. Okay, this is a biological issue. But be careful, because in the reality, you can be familiar with this picture. It's quite a Hanoi situation, actually. In the reality, there are endocrine disruptors. You know what are the endocrine disruptors? Are molecules which are able to bind and to destroy the hormonal receptors, in particular the estrogen receptors. And those substances are able to produce a lot of fertility and sexuality problems. And they are present into the drugs, in pesticides used in agriculture, in the plastic industry, in the bottle of water which is on your table, in the pollution, as well also in several chemicals. Those are the endocrine disruptors. The endocrine disruptor, as I said, this is the normal hormone, the healthy hormone, which is trying to bind its own receptor to make a biological response, the healthy one. But the endocrine disruptors is having a similar stereochemical conformation, and he is binding the same receptor, destroying the biological action of the receptor or increasing too much the action of the receptor itself, producing a response, a biological response, which could be tremendously dangerous. And this is producing many, many diseases. Like, for example, infertility. Like, for example, the lack of the reduction in spermatozoa number. And this is the list of the most famous endocrine disruptors. And you can see where they are. They are present in medication. They are present in, I think that here there are some dentists also They are present in the sealants of the tooth. They are present in the pesticides, and there are a lot of biocide products from the industry. And they are mimicking estrogens, though they are femininizing the population. They are inhibiting testosterone. They are inhibiting thyroid hormones. So they are doing a lot of tremendously severe condition where the cancer is just one of them. But there is something else which is very important, which is the oxidation. And the oxidation is related to another factor which is typical of our society, which is the presence of ROS, R-O-S, the reactive oxidant species, which is, for example, are used in several conditions, but also by the body as antimicrobial agent. However, they could be also very dangerous for the human body. And the ROS are also coming from political choices, from economical choices, so that you can understand which is the role of the society. And you can start to understand why I'm calling system sexology, because I wanted to draw your attention to the various systems which are producing health or disease. I don't know if it's working. No, okay, that was, sorry. Okay. Okay, so let's go here. This is very interesting article, very recent actually, which demonstrated that there is the ROS, for example, but also other factors are producing a kind of chronic inflammation. And that chronic inflammation is related to what? For example, to psychiatric problems, for example. And this is a kind of a cartoon, very, very interesting, because it's showing what's happened when there is something producing inflammation: smoking, pollution, too many cars in the street, polluted the waters, polluted the vegetables. So all those things are producing inflammation, which is damaging the body, producing chronic diseases, but also producing psychiatric problems, neurological problems like cognitive impairment, but also a kind of societal dysfunction. So it is a kind of new way to think about the sexual dysfunctions into the way that is related to the inflammation. And so they have been also able to establish a kind of scale of the inflammation, a scale of the inflammatory map, so that we can say that the stress transmitted by the others could be quantified by using those scales. And there is a kind of interaction between the social and the individual stress. And those are tremendously connected. As you can see in this very interesting cartoon, there is a society dysfunction and the citizen problems. And this is the typical situation, not just here, but everywhere in the world. And this is producing diseases. This is producing, in particular, sexual diseases. And of course, if a policy is completely ignoring the so-called green economy, the attempt to make the air more clean, the water more clean, and just thinking about economical issues, this is definitely producing a lot of diseases, a lot of problems. So I'm going to end my talk trying to convince you that if you wanted to do a very modern, a very new sexual medicine, you must think on four different legs. The first leg, very important, I called the system of the mind. The system of the mind is that one that is studying the intrapsychic, like depression, like anxiety, for example, factors, the relational, the relationship with the partner, as well the psychiatric one. And we call it the systems of the mind. But also, it is very important, the system, the second leg, the system of the experience. And the experience is dominated by the education, which is producing health of disease, by the religious context, as well by the cultural context. Think about the LGBT community health. This is tremendously influenced by the system of the experience of the people. If the people has been educated to be afraid of transsexual people, of homosexual people, of non-binary people, they will react also with violence. So the system of the experience is tremendously impacting. But as I showed you before, talking about the pollution and how the pollution is producing diseases, for example, there is another risk factor, there is another leg of the table, which is the system of the society. And that one is based on the choices the governments are doing. We are doing at home. We are doing in our small societies as well in the big societies, considering the society, considering the policy, considering the economy too. And finally, the last system, the last model, of course, is that one of the body, where there are unmodifiable risk factors like age and genes, you cannot modify, where there are communicable diseases like COVID, for example, non-communicable chronic diseases like cardiovascular, oncological, respiratory, and metabolic diseases, systemic diseases, oncological one, for example, toxicological, medical, iatrogenic conditions, risk factors, which are producing health or disease. And those four legs are all connected by each other. One is influencing the other, and the other is influencing the others, so that there is a unique way where each leg of the table must have the same aid of the other three. If you are considering only one leg, you are making mistakes. If you are considering only one leg or two legs, you are making mistakes. So that's the reason why I think that the system sexology model, it will be more and more successful. Also because the system sexology model is starting from the analysis of what? Of the lifestyles which are producing all those things, all the diseases related to those things, and the lifestyles is having on one universal pathogenetic mechanism, which is the inflammation, subacute inflammation, chronic inflammation, and you will find inflammation in what? In cancer, in cardiovascular diseases, in metabolic diseases like diabetes, in respiratory diseases, as well in psychiatric diseases, like depression, for example. A huge amount of evidences have been produced showing that into the brain of depressed patients there is a huge inflammation, chronic subclinical inflammation. So the attempt of the system sexology is exactly that one, to consider the four legs, the system of the mind, of the experience, of the society, of the body, to consider the role of the dramatic role of the lifestyle, and to consider the common pathogenetic mechanism of inflammation, which is exactly the same that you will find in erectile dysfunction, the same that you will find in a lack of lubrication, and in many, many sexual dysfunction too. One representation of this, you can find some authors that are familiar to you, where erectile dysfunction and endothelial dysfunction are tremendously connected, as in this cartoon. We use the same acronym. ED means ED. Erectile dysfunction means endothelial dysfunction. Endothelial dysfunction means erectile dysfunction, because the connection is the inflammation and the hypoxia, the lack of oxygen, which is producing the disease of the endothelium, which is producing the disease of the penis, of the erection. And this is absolutely the same for the vagina. And this cartoon is also representing how these things are so much connected. There are endogenous and exogenous sources of lack of oxygen, producing the ROS I mentioned before. And this is producing the oxidative stress, the stress of oxidation, a lack of oxygen, erectile dysfunction, as well the chronic condition that I mentioned before, from cardiovascular to metabolic to psychiatric one. And one way to use, let's say, the perspective of the system sexology is just a representation. It is outside our talk. It's just because it's something fun that we published this year. Is about the use of sexual toys, having a completely different perspective about it, and showing that the use of sexual toys may increase the sexual function, the orgasmic experience in female. Of course, if you are living in a society where the sexual toys are not allowed, where the sexual toys are not diffused, this will reduce the sexual health of the female. This is just a representation of it. So, using the model of the system sexology, you will have a more easy way to explore sex, for example, from an industrial perspective, like that one of the sexual toys, for example. So it is just a representation of what I mean when I'm trying to put together all those things. The idea of the system sexology is coming from the system medicine. System medicine is the part of medicine which is dealing with the non-communicable chronic diseases. And in particular, from this quite famous model of non-modifiable stressors or risk factors, like genes and age, and the modifiable risk factors like the society, the pollution, the epigenetics factors, the cultural lifestyle, the welfare and economical issues. And those are producing non-communicable chronic disease epidemics, but also impacting on what? On quality of life, on sexual quality of life, as well on survival. So that I have another acronym here for you, another like ED equals ED. Here is written SM equals SM, which means sexual medicine equals system medicine. And the system medicine equals sexual medicine at the same time. So in other words, what is true for the system medicine, the ability of lifestyle to produce health of disease, is also true for sexual medicine. So that we have this kind of terrible grass, which is the inflammation due to the wrong lifestyles, producing at the same time non-communicable chronic diseases and sexual dysfunction. This is the bad tree growing into the bad grass of the inflammation. But also sexually transmitted infections, because they are also very much related to what? To the behaviors. Also very much related to what? To the policy, to the choices of the government to help or not in the patients to face and to prevent sexually transmitted diseases. And once again, the mechanism is the same: hypoxia, lack of oxygen, ischemia, inflammation, and endothelial dysfunction, and cardiovascular and sexual problems. So this is a kind of very clear representations of this chapter we wrote for the International Consultation on Sexual Medicine last year, related to the connection between the inflammation and the sexual dysfunction. The system sexology can be also used to integrate traditional medicines, not just the Chinese one, because the system sexology is very open to different cultures, of course. And I think that this is another merit, because it's very able to adapt themselves to the different cultures, the different perspective, connecting, for example, the Western therapies and diagnosis, as well the remedies coming from traditional medicine into a unique perspective, which is the system sexology one. Something practical. Something practical is the assessment related to the system sexology. For example, you can explore the body, making those questions. What about your body? What about your sex? What about cardiovascular diseases, lifestyle, sexual function, and so on? But you can also explore the mind, how you are aroused, which one is the role of the parents, of the caregivers, how the education was impacting your sexuality, your experiences, did you have a previous sexual relationship, and so on. But also the experience in particular, the media are tremendously important. Unfortunately, the majority of our young generation are having sexual information, in the majority of the cases, wrong from the media. And this is really important, because it's opening a huge world of problems coming from the fake news, wrong perspective, wrong ideas. And of course, the society. Again, LGBT health, how your society is perceiving the gender issues. What about the economical aspect, how the money is influencing the sexual function, and how the society is expressing your sexuality, and how the society is a friend or a foe of your sexual health. So let's go, in this case, to another clinical case. It is an Italian one. Very, very practical. This guy, Mario, is one of my patients affected by gynecomastia. But this guy, he was unable to have sex because of the body shame of the gynecomastia. And during the masturbation, we use a specific tool, which is called masturbation erection index, that we validated, we demonstrated that his erection was below the normal threshold. So as endocrinologists, we found quite high, but not too high, close to normal, estradiol levels. So a little bit high estradiol levels. And the breast ultrasound showed that there is an enlargement of the glands of the mammals. But the society was tremendously impacting this story because Mario was living in the north of Italy. The north of Italy is a heavily polluted part of the country. And in particular, in that part of the country, there is a lot of endocrine disruptors that he is using daily. Furthermore, he is overweight, and he is using a lot of McDonald's, junk food. He's eating a lot of junk food. So the therapy, the real therapy was to change the environment and to improve the self-confidence of the patient. But at the end of the story, when he was dating with a girlfriend, an activist for the environment, vegetarian, and with a very careful idea of what is healthy, what is not healthy, those things was resolved in the case of Mario. So Mario was studied with the system of the mind, of the system of the experience, with the system of the body, but also for the system of the society. Because a lifestyle is tremendously impacting into a gender perspective in sexual medicine. Another clinical case. In that case, I wanted to bring you to Africa, completely different environment. So this is the case of Sarah. She is a princess of Kenya, one of the princes, a noble girl, very nice, very beautiful. And she was talking with us because of her anorgasmia. And her anorgasmia was considered by the psychologist as a psychogenic anorgasmia. And she underwent to psychotherapy, which was useless for addressing her anorgasmia. So she went to the gynecologist, and the gynecologist was telling her, "You are not sick. The lack of orgasm is not a disease. So go home, enjoy the life. I don't care of you." Okay? So she was completely anorgasmic, again anorgasmic, when she went to our observation. So basically, we discovered that she is a part of a culture in the middle of Africa, closer to the Victoria Lake, where the female are used to ejaculate during the orgasm, during the female orgasm. It's called female ejaculation. And this is very frequent in the other part of the Lake Victoria, which is Uganda. Not in the Kenya, but in Uganda. In Kenya, it's more or less forbidden, not so much discussed, while in the other part, in the other country, the grandmother are teaching to the girl, to the granddaughter, how to ejaculate, how to expel fluid during the orgasm. So when she realized this issue, when she realized that the possibility to ejaculate is something that could be granted, she started to have the orgasm. So Sarah was studied again from the system of the mind, experience, the body of the society, but no one alone was able to fix the problem. Only considering together also the cultural issue, I mentioned it before, she has been successfully treated. And this is the clinical case that we published in Sexes about her story. And the term that she used, "You shall make Lake Victoria Lake Victoria means a huge amount of fluid ejaculated during the orgasm. And when she was allowed to produce this fluid, she experienced for the first time the orgasm. So the conclusion number 5 is that our model, the new model, the system sexology model, is allowing to consider the environment, the time we are living, the patient is living, the society surrounding the patients, the gender roles, male, female, transsexual, homosexual, the religion, the culture, the healthcare system, the media, tremendously important on it, the schools, as well, all the systems which may produce or not sexual health or sexual disease. And the real merit, I think, of the system sexology is the fact that it is overcoming the typical dualism, the typical dualistic perspective, again, of mind in one part, mind and society in one part, and the body in the other part. So let's go to the very final conclusion. This is a kind of timeline. This is the first book published on the human physiology, 1966. The book of Master Johnson, with a huge risk of psychoreductionism, all in the mind, just in the mind. Then, 1977, Engel and the biopsychosocial model, very good, but with some risks. And the risk was also highlighted when the pill appeared, the so-called Viagra revolution, 1989, where the risk, another risk, the risk of medical reductionism, all in the pill, all in the mind, all in the pill. Now this year, for the first time, I'm presenting the System Sexology 2025 here in Hanoi as a way to overcome all those pitfalls, all those things which may really reduce our ability to deal with patient sexual health. And I wanted to conclude with a sentence that I'm pretty sure you are familiar with. To reap a return in 10 years, plant trees, but to reap a return in 100 years, cultivate the people, as we are doing here in the Hanoi Medical University. Thank you very much for your attention. Okay, again, questions if you have.